Thank you very much. I'd like to introduce my esteemed panel members. So we have Dr. Ishwar Chandra, my good friend. He's a radiology consultant, HOD here at Yashoda Hospital, and is a well-known figure. He was in UK for a while. Then he decided to return. And then we have Dr. Amrit Kadam, a radiation oncologist. He's again my good friend. He's based in Bangalore. He's an amazing person, a lot into AI. And then we have Dr. Sangeeta Desai, you heard about, you just heard, and she is so much into AI, pathology. I think pathology and radiology are competing. And then we have Ms. Sunita Krishnan. Hello, madam, how are you? She's a co-founder of Prajwala, and she does amazing work. Of course, you're going to hear from her. And then we have Mr. Seshu Venkat, again, my good friend. He works for Wipro, and he's a lot into AI. So that's a brief introduction about my panel, esteemed panel members. What we're going to discuss today is integrating AI systems into clinical practice. That's the most difficult thing. How are we going to integrate AI into clinical practice? AI on one side, clinical practice on the other side. But now, to bring them together, that's the biggest challenge. And that's what this panel discussion is all about. So we'll try to keep to the timings, because I think soon after that, we'll have to split. And then, how do you care delivering top quality treatment? So how do you work around that? So that, how you use AI for that. I just have 5 slides, quickly 6 slides. I will quickly run through that, and then I'll hand it over to the panel members, and they will take over. So these are very brief. Why AI matters now from innovation to clinical impact? Because of precision medicine, workflow efficiency is definitely helping us a lot, as I said before. Early detection, cancers are being picked up very early. I myself have seen so many cases where AI has picked up things which radiologists have overlooked or radiologists have missed. Not only cancer, everything, trauma, injuries. So AI is pretty good. Picking up fractures, because I do children, so pediatric fractures, it's one big area, especially non-accidental injury, but nowadays we call it suspected physical abuse. So that's one big medical legal area where AI is being used now. And better patient outcomes, definitely. There's no doubt about it. So the 3 big specialties which use a lot of AI are radiology. So here, detection, triaging, reporting, and then the clinical outcomes. Then precision medicine. So tomorrow we are doing a dedicated AI, half-a-day AI session in Pixel Hall. So there we are going to discuss all that. Pathology, digital pathology and computational diagnostics, and then oncology, planning, dose optimization, follow-ups. So AI has completely changed everything. Human plus AI is the best combination. So AI assistance, then we review the case, then we take decisions, what is the best treatment plan going forward, and then patient outcomes. And then AI augments clinicians, but it will not replace them. So it's just helping clinicians. And the clinicians nowadays, I think they have started realizing, and they are using more and more of AI. Ethics, equity, and trust. These are the 3 very super sensitive areas where still we are grappling with these problems. We are not mastered it completely. Privacy is one of the biggest problems all over the world, in UK, US, everywhere, because data can leak. And if data leaks, it can be disastrous for the patient, especially patient confidentiality and issues like that. So that is something which needs to be looked at more carefully. Transparency, again, AI tries to be too transparent. A doctor tries to keep certain secrets of the patients to themselves, but AI is too transparent. So that's the downside of AI. Accessibility, AI is easily accessible. Like Dr. Sangeeta said, if the patient's coming to you with full ChatGPT information, and they say, doctor, you're asking for ultrasound. ChatGPT says, do CT scan. Patients coming to us, and arguing. When we do the ultrasound, they tell us, why are you wasting time doing ultrasound? Because ChatGPT says ultrasound is useless because it's not accurate. So if I have appendicitis, why don't you do CT scan? It's only 85% sensitivity of ultrasound for appendicitis. So patients are becoming more and more knowledgeable. They're taking the doctors more and more to the court. So this is the downside of AI. I think we have to just be prepared for that. There's nothing else we can do. Accountability. I mentioned that already. Who takes the final responsibility? But any technology will only succeed when the patients trust it. We did a big survey at the Royal College of Radiologists. I'm a committee member in the Royal College of Radiologists. And we surveyed 500 patients randomly. And we asked them, are they comfortable with AI reporting their studies? We were quite shocked. Only 30% said yes. Remaining 70% said no. We want a pair of human eyes to look at those studies. Again, I don't trust a machine. So this was fairly recent, as in the month of May. Now, we have to wait and see what happens, how things evolve. Maybe over a period of time, the patients will say, fine, I think the humans are getting it wrong and the machines are getting it right. So we haven't reached that stage yet, but we don't know. It's a big question mark. Scaling AI across hospitals. So NHS is desperately trying to scale it across England because NHS is separate. You know, Wales NHS is separate from Scotland NHS, and England NHS is separate. So we are focusing on the English NHS. So the Scottish NHS, they have their own system. The Welsh NHS have their own system. But what they're trying to do is they're gathering data. So they're taking as much data as possible. And then infrastructure, they're trying to develop the infrastructure, pouring more money into machines. And then governance structure being strengthened. Every hospital has a very strong governance team. I also happen to be a governance lead for my hospital because I'm a lot into all this. And security. Security, we have cybersecurity experts who guide us, who are all the time available in the department. And they're constantly monitoring everything. What this AI is doing is picking up information from where. Sometimes it randomly picks up information from some other NHS trust, which is quite dangerous. So it can happen. And then clinical adoption. So are the clinicians happy to adopt it? So move from pilots to sustainable deployment. So that is the big challenge. And then the future outlook, if we meet again next year, things that have changed in the Indian healthcare because we used AI wisely. So hopefully, if we use AI wisely over the next 365 days, then hopefully AI should be our friend and not our enemy. So I have other friends also who come from Bombay. Sharad Maheshwari was here. I'm not sure whether he's here or he's in the other room. He's here. So he does a lot of the responsible AI. He's based in Bombay. So from Bombay, he does a lot of responsible AI. So, which is very important. So there's always a human in the loop here, and the workforce readiness. We have to see whether the workforce is ready for this, because training is the most important thing. Now what we are doing is the medical students in UK are intercalating. So they do first year and second year MBBS, and then they stop for 1 year, and they go into engineering. So almost 40 to 50% of medical students are doing that. That's called intercalation. So I'm sure it will come to India, because without an engineering background, it can be a bit challenging for the doctors to understand. Writing a few languages like Python and all that, if you know, then at least you can handle the engineers. Otherwise, handling the engineers can be a bit of an intimidating task. They're very nice people, but they're always waiting for the edge. And then workflows readiness. So we have to see whether we are all prepared, and India should be leading, and that's what we should all try. The good thing about India is the regulation bit. Here, I think ICMR is less hawkish and more opportunities in India, whereas in UK, they're very, very hawkish. There are so many well-tested algorithms which are still not validated in England. It's because the MHRA is so hawkish that they take their own time. They don't want to rush into anything and just validate a program. So this is about my introduction. So I'm going to start with Dr. Ishwar Chandra. So Ishwar, please.
Should we come in the center?
No, it's okay. You carry on, please.
If the slides are no more there, we could perhaps come in the center.
Where is you got the slides? Ishwar? Okay, it's fine. You carry on, please. You want to say something? Ishwar is a consultant radiologist based at Yashoda Hospital. So they're using some algorithms here now. So he will tell us about it and his experience.
Yeah, thank you, Shivakumar. I think I should thank Shiva for introducing us to AI in 0.0 3 years back. Last year we were at 1.0, where we're taking some baby steps, and now we're hopefully going forward in that implementation. In the past year or so, we have implemented or tested, I would say, not exactly the full-scale implementation. We tested for predominantly for chest radiographs in early detection of nodules and detection of abnormalities. Number two, we also tried to quantify disease on CT scans of the chest to quantify disease such as interstitial lung disease, how much of the lung is involved, so that that could help the clinicians in tailor the medications, whether to increase or to decrease, etc. Prostate cancer detection at MR, we have done a pretty decent job. The algorithm was good. So I would say that the challenges would be in terms of having a single model, a multi-agentic model doing this multiple things. Like for instance, we only have models now which would say that there's a brain hemorrhage or a cancer detection, etc. But as administrators or as radiologists, we would want to have a complete set of diagnosis on that particular single imaging investigation. The challenges again would be from the administrators or the patient's side is they would want a complete diagnosis which is foolproof. Either it would be an AI or radiology related opinion. I think it's a win-win when both AI and radiologists are both in the loop. So we have found situations where radiologists missed certain things and AI helped us, and it was vice versa too, where AI overcalled some artifacts as cancers, and we as humans in the loop could fine-tune that. Thank you.
Thanks, Ishwar. And the one point I'd like to add is if the radiologist misses something and if AI picks up, the codes are very, very tough on the radiologist. The code catches the radiologist for missing it. So that's why what we're doing now in UK, the radiologist first interprets it, and he stopped doing that. So now the AI does it. The radiologist says, let AI have a look at it first, and then I will go in, because of the litigation. So this is one very sticky area. So I'm sure this is going to come to India, and this is going to get more and more worse. Okay, thanks, Ishwar. So I hope you were able to just get an idea as to what's being done at Yashoda Hospital. I think in other departments also they're doing quite a lot in pathology. Milap is doing in microbiology. There's lots going on here in Yashoda. Robotic surgery, Chinnababu is doing. So there's a lot to be learned. And if you guys are working here, then please use this opportunity. So yeah, Amrit?
Okay.
So Amrit, if you could tell us a bit about what's your area of expertise and how you are using AI in radiation oncology. The last year you were here and you gave us a brilliant insight into that. So if you could tell us a bit more, please.
Sir, as you know, radiation oncology, we use a lot of imaging techniques. So we actually use the segmentation, registration. We actually use CT, MR, PET scan registration so that we are able to delineate the tumors. So if you see, all radiation oncology is, as a specialty itself, we are all computer-based. So I think it's a natural step that we start integrating AIs, because most of it can be automated as such. And I still remember 20 years back when I started radiation oncology in a private center, when we were contouring, I used to take 5 hours to just contour all the structures. So now that happens in just 10 minutes without me being there. So that is the difference which is happening already. So that is one key area, I think, in the initial steps. And I think in a country like India, where there are deficient number of doctors, we are not able to, as per WHO standards, we are not able to reach that standards. So I think AI will help us triage these patients because it will bring up prioritization of patients who who are suspicious of cancer, and they'll be able to reach access to care. And AI, I think, in India is going to reduce this gap. There's a large access gap between urban and rural healthcare services. I think AI is definitely going to do this from the screening point of view. Coming back to decision making, all our decisions are usually based upon the tumor board decisions we make, where we have all the specialists in place, but most of our systems work in silos. There is no compilation of it so that everything is structured and presented in the right way for the discussions to happen. Because in a tumor board, typically we have maybe a minimum of 5 to 10 cases. That is provided we prioritize all the patients, and maybe we'll have 5 to 10. Otherwise, if we are supposed to bring all the patients there, it's going to take one whole week to just do tumor board. So which is again which is a time intensive process. So tumor board in AI we have been using, this helps us in actually critically picking up things which require discussion, and it will bring up key discussions. I think one of the speakers mentioned about ambient listening. So if this is also plugged in, it will show up any sudden doubt or case we have, and it will tell us the latest trial which is happening in this scenario. And in tumor board, the AI models which are being used, it will actually give them context. For example, there was one of questions in the audience which mentioned that somebody uploads for Sunita madam's thing. They just upload that digital pathology slide and they get jabbed. ChatGPT does not have context. So in tumor boards, when we give, the patient's data is also entered. So all the details, the history, what is happening, if there is any previous history, all these things. So without this AI, I don't think so. It'll be a human large task to just compile all these discussions and present it. Maybe in this 10 cases what we take, we gave 5 minutes for each patient for us to decide. So this is where I think it will have.
Sure.
And
yeah. Again, we use regularly AI in all the MDTs, the multidisciplinary team meetings in oncology, different specialties, especially more so in urology, and it is really helpful. And then we are doing a lot of mapping in neurosurgery. So pediatric neurosurgery, I work at Great Ormond Street Hospital. I do 1 day a week at Great Ormond Street Hospital, and we are using, the neurosurgeon does AI mapping and removes the tumor, just right down to millimicrons. So absolutely zero neurological deficit. It's brilliant. And they use 7 Tesla scanner. So there's no way, even focal cortical defects or FCDs, focal cortical dysplasias, which are missed by 3 Tesla MRIs, picked up by 7 Tesla. And it can be beautifully mapped with AI. So, thank you, Amrit. So we'll move on to Sunita. Sunita, you had messaged me about that. Your question was brilliant. You had messaged a nice question, right? About patients. What's the patient's perspective? So, yeah, please tell us more about what you do and how you're using AI, please.
Dr. Shiva, thank you so much. My name is Sunita Krishnan. My mission in life is to save girls from prostitution. I have saved around 32,000 girls out of prostitution and run one of the largest organizations called this Prajwala. But I'm sitting here more as a patient. I'm in my 4th stage lung cancer. And after 4 years of medical tourism, I see what AI can do and should not do. And I think a couple of things that I would like to flag from a patient's point of view. Every patient wants a certain amount of certainty and assurance that this is the real diagnosis. But what AI should not be doing is to understand that it is only an assistant and it cannot do diagnosis. Far too much of anxiety is created in the families of patients when an AI starts giving diagnosis and predictions and things like that. But something very bigger importance is that patient is not a data, it's not a number. They're real persons who have real emotions, anxieties, dilemmas, confusions, fear, and so is the ecosystem they come from. It could be a father, mother, it could be a spouse, it's a whole family. Something like what I have, cancer, can devastate a whole ecosystem in terms of not just my family, but my extended family who depend on my existence. So to look at that aspirations of the patient, that I'm heard, my anxieties are understood, my fears are understood. And the third aspect that I want to flag is, I think AI is as good or as bad as what we feed it. And therefore, the ability to evaluate continuously and upgrade itself continuously, I think is what a patient would require the most, because anything today with technology is outdated in matter of days. And to give a patient outdated information, which is archaic and which is not precise, is doing more harm than good. And I like to stop here. That is few things that I am flagging as a patient to all the caregivers here.
Amazing. Big round of applause again for the great work she does. It's an amazing community service she does, and especially being a cancer survivor, this really needs a lot of courage and mental strength.
Not yet a survivor.
We hope.
Dr. Shiva, here, downstairs here.
Oh, sorry.
Downstairs here. I think just take a little small thing from your panel.
Yes.
So just would like you to listen to the NEJM AI, which actually put out its other on June 11th.
Yes.
So the frail older patient with a kidney disease, diabetes, anticoagulation, recurrent falls, limited transportation, and an exhausted daughter is not a sum of 6 guidelines.
I'm still working for the NHS, so I'll keep my lips tight. Right. Okay. Wonderful. Thanks for that. Shall we move on to Dr. Sangeeta, please? Your talk was amazing, brilliant. I had a few questions on that, but I will let you do the talking.
What's your question?
Tell us about, in pathology, because in our department, in our hospital, pathologists are really, it's a game-changing, right? AI is game-changing. The reports are coming back so quickly. It used to take 2 weeks, 3 weeks, but nowadays we have, within 1 or 2 days, the reports are back, and the reports are accurate. They don't want a second opinion. They say, I'm fine, I looked at it, AI has looked at it, I'm more than happy. I don't need a third opinion, which is really good, a big relief for the clinicians. And also breaking the news to the patient. I think, I'm not sure about your experience, but at least in our hospital, AI is really trustworthy, and so far we have never had any undue issues. The patients are very happy, and the families are very happy. So I'd like to get your opinion on it, some insight into this.
So what happens in path is, it's not AI. It starts with digital path. So first establish digital path, and during that process, you are automatically improving your laboratory infrastructure. So many of the problems which are associated with the archaic type of laboratory architecture, those problems get addressed when you introduce digital path. Then the next step is AI. Now, AI algorithm, when it comes to you, there are many in the commercial space, many in the research space. They want us to test their algorithms. So they come to us, but as pathologists, we have to ask them, how did you generate this? How did you create this what kind of populations, just to ensure whether they have paid attention to generalizability or not. There are many hidden biases in during AI algorithm development, whether they have been addressed or not. So all these questions need to be asked, then validate in your own system, real time, real data in your own laboratory before accepting that algorithm. It may come from the topmost world leaders, but the local validation is of utmost importance. Then introduce in your clinical flow. So that has been my understanding about AI.
Absolutely, it's so important because at the end of the day, I think every department has its own rules and their own system, and the clinicians are used to that particular way of working. And in our hospital is also like that. In spite of AI, still the clinicians, they say, oh, still, can Mr. Smith have another look at it, please? Well, I think it might take a while for that to go away, right? Because you're still so obsessed with certain personalities, and you think, I can't trust this machine, which is fair enough. Absolutely, it's fine.
Actually, with in very busy or high volume centers, AI can be of great help in, say, per day there are thousands of pap smears. So AI can, siphon off those which are absolutely negative. The trainees can have a look at them. They can separate some 100 which are positive or borderline smears. So pathologists can actually conserve energy for better,
Yes.
tasks,
Tasks,
better
yeah.
tasks.
Absolutely.
That's the
I think the radiology also it is the same, but slightly different. So it definitely, and again, I think the big advantage is working remotely, and transportation used to take time. Samples get mixed up, wrong patients, wrong names. All that is taken care of by AI now. So it's a big relief. Thank you, Dr. Sangeeta. And last but not the least, Seshu Venkata is from Wipro, the man who designs equipment and throws them into the market. Go on, please. Tell us a bit about what is the latest you're doing in this field, and also, your insights, very valuable insights.
Very good morning, good afternoon to all of you. In front of all the doctors, radiologists. Very good afternoon to all of you. I think in front of all these doctors and radiologists, I don't think I'm in no way qualified to talk about medical SLMs and LLMs. But I will talk about what we are doing to help our customers to move the AI systems from POCs to the production systems, right? Even if you look at the healthcare POCs, right? A lot of them, they look very impressive at the POC stage. But when we try to put them into the production, that's when actually we start hitting a lot of roadblocks. Right? So predominantly, we are working with the customers across all sectors, manufacturing, energy, consumer, and healthcare. So I'll focus more on what we're doing with our healthcare customers. Right? I think there are 3 key engineering pillars that we focus while helping our customers to move these AI systems from POCs to production systems. The first one is moving away from data snapshots to data pipelines. Because when proof of concepts are done, they're done with clean and curated data. But when we get into the real world, the data is not clean. So you have the continuous data coming from your medical records, scanning systems, right? And then you face patients with different demographies, right? The data, the quality is changing all the time. So we need to put the systems in place that can deal with this chaos in the data. Unless you have a quality data pipeline management system, the AI systems will not work efficiently, because the output of any AI system is as good as the quality of the data that you are feeding into it. Right. The second part that we have to pay attention in adopting, even if the system is good, still we fail with adoption. we need to focus on workflow embeddings than workflow additions. We build a great AI system and then you take it to the hospitals and doctors. But if we have to add a couple of more tabs where the doctors have to feed additional data or the clinicians have to feed additional data, it's only a week's time before the system goes down. Right? So these AI systems should be embedded into the EMR workflows of the clinicians, and it should, at best, they should be able to reduce some of the steps that they have to do rather than adding more steps. The third element and the most important element is the human in the loop, and then a continuous model drift management systems. Because typically the POCs, when you do a POC, it freezes in time. But when we put the system into the production, there is a continuous evolution of the diseases, right? There is a demographic shift. So we need to put a model drift management system in place that is continuously checking the efficiency of these models. Otherwise, in a matter of 6 to 12 months, the efficiency will go down from 90% to 70 or 50% without even knowing us that actually its efficiency is going down. Then naturally, right, we start getting all these legal cases and so on and so forth, right? So this is where we need to have the model drift management systems that can continuously monitor the efficiency of the recommendations coming from these systems, right?
What's your experience about, the drift? As you mentioned the drift, that's one. And are you using the digital twin for that, to overcome that, and to what extent it helps? And also I want to know whether you're still having lots of hallucinations.
I think it's an important question, and I think this is the holy grail of the AI. Right? I think there are multiple ways we are actually trying to manage this, or try to provide solutions to the customers. One is certainly implementing a digital twin, for the systems, so that we can evaluate the responses, and also setting up eval systems, and also using a higher model, to validate the outcome coming from the model that we are using. So it's kind of a multi-pronged approach that we're taking to handle the hallucinations.
Sure, wonderful.
And of course,
Thank
the
you.
human in the loop is always
Of course.
something that is essential to deal with these hallucinations.
Thank you so much. I'm going to throw the floor open for questions. Please feel free to ask questions from the panelists. Anyone? Do you have any questions on what we have been discussing? Yeah.
Here you are. Please introduce yourself and ask the question.
Good afternoon, everyone. I'm Sergeant Captain Dr. Vijay. Absolutely amazing panel discussion. But one point of concern is when we are introducing an AI model, the validation is very important. And most importantly, continuation of the validation is also more important because the system is going to evolve. So at what point can we say that the system is actually validated? Because AI has come up recently, probably 2 years. Don't we think we require more studies, more amount of things when we introduce any kind of system into the environment? Thank you.
To whom is the question? Is it to AI in general or to?
Any of the panel members can take it. That's fine. Absolutely fine.
Thank you, Doctor. I think that's a very important thing. Currently, whatever AI projects which are in place in our department are under the validation mode. I think that's a continuous thing. At least 5 to 10% you should be validating your data on a continuous basis. And that's a very important thing as well. I agree with you, absolutely.
Can I add to this?
Yeah.
Yeah, actually in my talk I mentioned multimodal Artera test for prostate cancer. Now that's the best example. Why? Because it was developed in clinical trial setting. It was prospective validation, and it was tried on more than 9,000 patients in several clinical trials. Okay, so that's the best model, but it doesn't happen with AI always. So many are in fact retrospective studies, and then still those algorithms get approval. So that's why we have to be very careful with local validation.
Absolutely. Any other questions, please?
Yeah.
Go on.
Yeah, I'm a neurosurgeon from working here. In fact, I gave one study to my postgraduate where I think Ishwar also knows it. There was 10 cases of spinal infection as a radiologist. And when all the 10 cases were uploaded into ChatGPT, all were reported as a tuberculosis. Whereas in reality, they were something else. I mean, some turned out to be, micrococcus. So in that instance, when there is no precedence of these infections which are recorded in the data, obviously that's going to be, will not be recorded in the GPT output. Secondly, when I sit in the outpatient in a lighter note, I can make out the patient who has already been fed by the ChatGPT versus who believes me. Obviously, ChatGPT guy is fully tensed, confused. He tries to ask more questions, more wide. I think this is for the gentleman in the last two.
Right. So, I think, in terms of, the trusting, right, the human versus the GPTs, right? So, or the AI systems. So it all kind of, the boils down to, the types of issues. For example, today the models are, good at giving some specific information, than humans. For example, you want to discover the best price for a, a mobile phone or something that you want to buy. Perhaps I think, they're very good at it. But when it comes to the special, disciplines, right, like the medical healthcare, right, they're still evolving. So, but in these disciplines also, I think that today, if I have to say, the maturity of these models is at a stage where they can actually help the professionals to do their job better or faster. Some of the mundane activities, probably they can do faster. Okay? I think that's where the technology is at. I think these are the things that we need to continuously educate to the common public.
Yeah.
Right? So where it is good at, right? If they want to, buy, a specific medicine at a better price point, right, or an equipment, probably yes, it can tell. But
do
right?
you think that at some point, like in England now, children below the age of 16 are now, they're being restricted, given restricted access to internet because the crime rate has gone up in London and in England in general. So the government is thinking that it's all coming from the social media. All these young children are exposed to all sorts of violence and all that. So now, just like Australia following suit, UK is also doing it, but there's a lot of hue and cry. Freedom, freedom rights. There are lots of lawyers. They are up in their arms and saying that no, children should have access to social media. Don't restrict them. We are not Australia. So the question is, my big question is, do you think that we are going to have at some point some kind of a very strict regulation on ChatGPT?
I don't think you should
it's becoming a problem.
Single out one particular LLM.
Oh, sorry. Okay. No, I mean, okay, some LLM. Okay, I'll be non-committal. Otherwise, I'll be hanged. It's fine. But what I'm trying to say is, don't you think that the patient should be restricted? They're having free access to everything, and it is proving very dangerous.
But Dr. Shiva, that is one end of the spectrum. Another end of the spectrum is genuine last mile connectivity in a country as big and diverse as India. Are we ensuring that this technology reaches the last person, the poorest of the poor, the most needy, and to say the public sector, the public hospitals? So at one end is people who have it and have it more. How can they use it and misuse it and create all kinds of confusions? Another end is a huge section of the population who do not even have access to this. How do we balance between that and customize it to the needs of this country?
I'm acutely conscious of the time. Thank you for that, Sunita. I think it's very important that India, 1.4 billion, not easy to govern, to get access, because even when they were trying to marry Aadhaar card to the Aadhaar card, they found it difficult because there are a lot of people who don't have access to computers. I'm going to take one final question. Yeah, please. You've been waiting for a long time, sorry.
Thank you for...
It's okay, ignore it, don't worry, ignore it.
Okay, thank
He
you.
has given me special permission.
Thank you very much. Appreciate it. Hi, my name is Rashmi and I represent Technogen. We are also, we are an IT firm. And of course, like the whole world is moving towards AI, we are also exploring AI and implementing solutions. My question to the panel is, since we have both care provider and a care receiver also in the panel, I know AI, everybody is talking about it, but what happens if AI is taking over everything? Where is the element of care and that concern and that human touch that mostly a lot of psychologists say that is what heals the patients more than medicine? What happens to that?
So I think to answer to that, we can have a detailed discussion later, but to answer to your question, so the thing is, AI models are algorithm based, similar like that, and they are very good at recognizing patterns. But for example, if I'm sitting in a clinic, that I have a guidelines which with me. If I throw it to the patient has different ways of looking at it. He will look at it financially, he'll look at it socially, how it is affecting him. Then he will see what is the social environment he is in, whether his family is able to, for example, for radiation, if I ask him to come for 6 weeks of treatment, he will see if somebody is there to come accompany me on a daily basis. These are multiple challenges. So decisions are never based on these algorithms, but again, financially also, if patient is able to afford it or not, something like that. So there is a lot of, the best way as an IT company, I think, I echo your thought, like many people have been asking, unless doctors join hands with tech people, I don't think so it will work. And there has to be, like Sunita Madam said, we have to have a seamless way of integrating technology into our practice. Because if you are asking me to go and sit in front of a computer, you are taking my time away from a patient. Why will I use the computer? I better spend time with my patient. That way the patient is compliant with whatever treatment I am suggesting. So these tech companies, which I've been, many people who I mentor, I've been telling them that there has to be very less friction involved when you are trying to bring in healthcare. Because each and every action or decision we take, it has a consequence. So we are very, very mindful of that, which very, very challenging scenario. And it cannot be generalized and told because it happens to each patient we see is different. So this is just a snapshot I can tell you.
Thank you very much. And thanks everyone for being so patient. And thank you panel members.